tired as I believe a person can get. So put this up just because these cookies, another topic that's of great interest to me is gut health. And, you know, everybody's drinking the probiotics and you're always wanting to get all of that and everything. And we have the capacity to populate our guts with the beneficial bacteria that digest our foods and produce the short chain fatty acids that are the anti-inflammatory agents that we're striving for better health. And so we can drink them and we can eat them in our yogurts and we can do things like that, but we can also eat cookies like these that have the appropriate fibers in them that help to propagate the beneficial gut bacteria that, you know, we don't digest our own food. I always look at people and I say, you know, who are you having dinner with tonight? You're not eating alone. We've got a huge gut microbiota that is, you know, actually helping us digest our foods. So these cookies are good. All righty, I am going to switch into a presentation mode. And as I was saying before, it's been a long time since I've seen a desktop computer.
We do things old school here.
Well, it's good for me. I feel my incompetencies. Okay. So the topic hasn't changed drastically, same meaning, but you know, when I agreed to come in and give a talk, I can't even remember exactly what that topic was, but it means the same thing. We're just looking at just the impact of poverty on health outcomes. And I think we all are pretty aware, no big surprise, right? Kind of been unequal treatment. So I'm just curious. I would rather, instead of me just kind of being the sage on the stage, I'd like to start off by asking what some of your impressions are about this topic. And it can be globally, it can be nationally, it can be right here in Yellow Springs, which, you know, we're probably very representative of the other two. I don't think we're immune to anything, but does anybody have a kind of a preconceived notion? Judith?
I think that one concern is that people who are poor and don't have health care don't get timely intervention and help, and therefore their lives can be ruined because of whatever condition was not treated early.
And is it their fault?
Never. No.
I was going to say the very thing.
Correct.
I had a son who was very sick, born with an abnormality. Couldn't touch him. He died, leaving me with $130,000 in hospital bills in 1984. It was diagnosed him.
Oh,
Yeah, he died in the back seat. In the hospital.
yeah, they're horror stories. There's no doubt they're horror
They
stories.
But that's awful. No one should have to go through that. No one, we didn't ask for that. He didn't ask for that.
No.
A little compassion, I think, would go a long ways.
Yeah, that's what they're leaving out of the curriculum now.
Yeah, I've been thinking about this the last few days. I'm going to my 55th high school reunion tomorrow, and we just had a presentation of those who have died in our class, and 70 people out of 240 have died, which was astonishing to me. And we saw who they were and their faces, and they were the lower income folks in our town in North Louisiana, and it's just glaring to me that they had shorter lives than those of us who were higher income. So.
Yeah, it becomes a primary care issue, and it doesn't start as a primary care issue. And that's the part that is sort of my soapbox, you know. It's just it grows into a primary care issue, which is doctors, nurses, and it's just not the way it starts off. Though, anybody else want to just chime in? Now, I've had 34 years of teaching evaluations, and I speak in a monotone. So if nobody has anything else to say, you've asked for. Here I go. It's just I don't know what to do about it at this point. Probably nothing. Then they say if I try to talk differently, then when the students knew me well, they would laugh because they say she's trying. Anyway, I'm not going to try. Okay, so It is, as we said, there's a history of income and health outcomes. It's hardly a new observation. Everybody in here is already aware of it. I don't think it's going to be a lot of new information, but I have put it together into a story, just storytelling and putting it into context and doing a little bit of trend identification that when you see how this is all unfolded over time, it's going to make you really mad. If you think you don't feel good about it now, yeah, wait till you see what we've been doing. So we know that the individuals living in poverty endure worse health outcomes compared to people in other social strata. The impact of poverty on health outcomes is well documented. And so that's a catchy word in this sentence, dating back to when and where. So documentation is different than just some casual observation that, hey, we think that people of lower SES aren't doing as well. And then the process of how we basically accuse them for their own health before we start to prove otherwise is another part of our progress. But anybody have any idea when the first documentation happened and where? So 1817 and France.
Wow.
And this was with contagious diseases. So this is another interesting thing. Boy, have we gone full circle. We go from contagious diseases through a history of other stuff that I'm going to talk about. And where did we find ourselves right back in the thick of in 2020? Back to contagious diseases, with the COVID situation. And the interplay between all of this is fairly astounding. So at that point in time, they thought that just poor people were dirty, and that's why there was more disease in those areas. And there has been a fairly windy little path of progress. And so this is just looking at, during the second. So I've taken a deep dive into one contagious disease because it's a bacteria. We could look at all of them, but this, we don't have time. That's a whole course within itself. But just looking at cholera, during the second cholera pandemic, which went from 1816 to 1837, the scientific community had varied beliefs about its causes. You've got to figure out what's making people sick for 20 plus years, right? Okay, and a lot of death associated with this. So, and you can be reading ahead, that's fine. I sometimes put a lot of stuff on the screen. I personally don't process auditory information very well, and I have students who either are going to get it auditory or off the screen. And so I usually provide pretty in-depth slides. So in France, doctors believed cholera was associated with poverty. Well, we just read about that. Right, 1817, that was kind of the first observation that got documented that, hey, people living in poverty are having an overrepresentation of this, whatever this disease is. They didn't, have a name for it yet. They had no idea what caused it. Russians believed they were a little ahead of the game. It was contagious and they quarantined their citizens. I would have hated to see that setting. I wouldn't want to think what that being quarantined looked like back then. Right, everybody stacked on each other. But the United States believed that cholera was brought by recent immigrants, specifically the Irish were to blame. And the British thought that the disease might be due to divine intervention. So, it spread, and it was in 1834 that it actually made it into our country. So that's a long time of having a lot of people sick and dying with nobody really knowing what's going on. And that's when you start getting into somebody has to have interest in the science, right? So we've got this guy named John Snow. He's very famous in our world because in 1854, that's still 20 years later, okay, that he thought that it was due to the handle on a pump. This is a huge revelation. He's not blaming it on poverty. He's not blaming it on being Irish or being poor. He's narrowed it down to it being on a thing. There's something on that handle. That's a huge leap in thinking, because that means that theoretically someone rich could walk in and get that hold of that handle and maybe have the same problems that the poor people are having. Okay, so takes a while for people to grasp that. So he believed that it was germ contaminated water, thus the handle on the pump. Previously, it had thought to be airborne, and it was this miasma theory. And John Snow didn't identify what the contaminant was. But that same year, another scientist came in and isolated the cholera bacteria. Okay. And that was the causative agent. So this was very, very important in opening up how we're going to be able to handle some of these things. And then why he actually published his works 1 year later. So in 1844, he made the discovery, 1854, he made the discovery, discovery in 1855. He published that, but it was many years before people would let go of that miasma theory that it was airborne. You know, and was, you know, they just couldn't grasp that there's something living on the handle. And the airborne theory, they didn't have an idea as to what it was in the air, you know. So you go back and we take an awful lot of knowledge for granted as we entered into 2020 with our new contagion. So, but when these discoveries started coming about, then we started having improvements in the socioeconomic conditions. So we had things like sanitation improvements, right? You know, I mean, do you know what the streets used to be like? Just ungodly, you know. Sewage disposal, clean drinking water, running water, antibiotics, medical practices, and improved health systems. So hygiene improved, living conditions improved, and some improvements in nutrition, but mostly in not having contaminated food, not so much about nutrient composition itself. So this helped to bring a lot of these infectious diseases under control. So we've got contagious and infectious diseases, the things that I can give to you and I can get from you and we can spread. So that means that many of these major killers from like 1870, so like against smallpox, typhus, yellow fever, scarlet fever, cholera, a lot of these things were coming under control because of these improvements in the socioeconomic environment. So they also were followed by advances in health status and life expectancy. People started living longer, okay? But what else was happening at about this time? So think about 1900s, okay, getting on through the course of the 1900s when all these socioeconomic improvements were happening, and we're starting getting, you know, things like indoor plumbing, running water escalators. We're starting to have a lot of advancements. So there was the hygienic part, but at this same time, think about, you know, mid-century.
Development of antibiotics and things like that.
Yeah, we had a lot better, yeah, on the medical end, and that's still thinking in how to handle some of the contagious, you know, problems and things like that. But isn't this when we started getting lazier? Oh, Western lifestyle started coming in, right? It's concurrent. It's all happening at the same time. You've got the scientists who are, you know, progressing in how to try to take care of the contagious diseases and all these things. But then you've got all of the other people that are also thinking about ways to improve our lifestyle. Okay. And so with that, that's where you start getting into indoor plumbing, escalators, all of these things. Okay. Vacuum cleaners, automobiles. You know, things that we didn't have earlier, but it makes our life easier. And then processed foods, they would, of course, be my demon of choice up there. But so anyway, and who's always the first? Who do you think got the hygiene benefits and all of that first? And who do you think got the, who got their own car instead of public transit? The wealthy. So higher SES is getting the benefit from all of these convenience factor developments. They were already getting the first benefits from improved hygiene, healthcare systems, and medicine and antibiotics and all of that. Whereas people of lower SES are always going to be a little behind in getting to adopt those types of things. Okay. Was it,
Her SES is.
Oh, socioeconomic status. Yeah, thank you for asking that instead of just going on. So the next thing that I would like for you to kind of think about is we've talked about, well, we started by talking about contagious diseases. And what is the time course of a contagious disease? You know, if you think you've been seated next to somebody with a cold or something at the movie theater, how long do you think it is before you are going to have that cold?
72 hours maybe.
Yeah, exactly, right? Okay. And so that time course from exposure to manifestation of symptoms is not very long. Okay. It's kind of easy to start establishing some cause and effect, right? Well, here's the bugaboo. In all of this, my modern convenience failed me.
Aw.
Oh, there we go. Contrast. Now we're going to look at a different type of a disease manifestation. And that is going to be with all of our conveniences. And I said, we got lazier. We started eating processed foods. Okay. What happens when we don't have healthy lifestyle habits? We don't have a cold in 3 days. But over time, think of a lifetime of low levels of physical activity. Think of, you know, poor dietary habits, smoking, alcohol. I think I've got all my favorites covered. No, I don't smoke.
You get chronic diseases.
Cancer. All of that. You're all exactly right. It takes time. Well, guess who the early adopters were? The rich people. They got all the conveniences. So while we got the contagious diseases under control, and that's great, first in the wealthy and then trickle down, we did start taking care of it in the lower SES, you know, neighborhoods and things like that. But all of this time, what's brewing inside the wealthier early adopters of all the modern conveniences are all of our NCDs, non-communicable diseases. You can't catch them. You got cancer, I can't catch that from you. Okay? Heart disease, diabetes, any of these things, I cannot catch that from you, so they are non-communicable. But they are the definite downwind of all of our conveniences that we adopted in the 1900s. So it takes a long time. So it made us kind of slow to realize that convenience is the non-communicable disease companion. So now remember, who are our early adopters? The wealthy were the early adopters of all. I keep looking at you because every time I ask that, she goes, oh. So, yeah. And so guess who's getting sick? The wealthy. Well, that's a 911.
It's hard being special.
Yeah. Yeah. So they became overrepresented in the presentation of NCDs. Lower SES folks were healthier than higher SES. Oof, that really makes the higher ups mad. Socioeconomic progress actually created conditions that have favored the rise of chronic, non-communicable diseases. Ruh-roh. Looks like this shoes on the other. 911, the wealthier suffering. So There's the fact, health follows wealth. When these non-communicable diseases were conditions typical of individuals with financial wealth, scientific community, governmental agency, they focused on their remediation. Okay. Funding and research. I mean, I got a good bit of funding when I first got to UD for this stuff, you know, millions. But it continued from the 20th century, it continued through about 2010. The funding and everybody's focus on all this. That's when significant progress had been made in reducing the NCDs in the higher SES cohort. 2010 is about the time that we got that more under control. Okay. Funding dried up for this in 2010. Just dried up. So where are we today? Women on this side, men on that side, and these are deaths in millions. One interesting thing to note is that the gray is always going to represent your communicable diseases. Okay, so for kids 0 to 4, the communicable diseases are still going to be it. Well, they don't have a lot of time to become ill with the chronic diseases. And Wendy, who lives in my rental house and has for years, she's a trauma counselor, and I was talking to her about this last night, and she said, I'll bet you they don't mention anything about gun violence and how many 0 to 4-year-olds that kills. And sure enough, they show it as other injuries, but the majority of those are gun violence in little bitty kids. So not the topic of interest, but I got way off on that talking with her last night, is the pump in her septic system was not working. That's why we were brought together last night for a while. Okay, just age groups advancing, women, men, similar patterns. All of the, you know, like from peach color and all the way up, these are all the NCDs, okay? When you consider that COVID is taken into account here.
Oh.
What is the NCDs stands for?
Non-communicable diseases. Yeah, and thank you for asking that. So the SES is socioeconomic status, NCD is non-communicable diseases, okay? And yeah, so the toll from non-communicable diseases is exorbitant compared to anything dealing, even, this is from 2022, COVID's done come and went, you know? And look at the size of magnitude of COVID, even in our elderly, relative to non-communicable diseases, okay? Okay. And I'm reading this because these are just facts that I don't know, memorize this stuff. The point is clear, but non-communicable diseases kill 41 million people each year. That's equivalent to 74% of all deaths globally. 86% of these premature deaths in individuals under 70 occur in low and middle income individuals. Okay. Of all non-communicable disease deaths, 77% overall are in low and middle income countries. But regardless of national wealth, low income status is your death sentence. So it goes into low income countries, it goes into developing countries, it goes into developed countries, wealthy countries. But individuals living in low SES are not going to get a fair shake. Cardiovascular diseases account for the most NCD deaths, or 17.9 million people annually, followed by cancers, 9.3 million, chronic respiratory diseases, 4.1 million, diabetes, 2 million. And these 4 groups of diseases account for about 80% of all premature NCD deaths. And premature means before 70, okay? So this information is from the World Health Organization in 2022. Most of the NC deaths are in low-income people, and they're largely preventable, but there is no funding being directed toward the NCDs.
Hey, just a quick question about
Disease in women.
that in Germany, studies about heart disease in women for a long time, right? It's mostly
Yes, thank you. Everything was done on the physiological male, because that was who mattered. And then white women came to matter a bit, you know, but you're exactly right. And I mean, I've got tons and tons of it, you know, close to 100 original research articles published, but I did so much with African American women and their biological children in Dayton and Xenia, but Appalachian White and Xenia. But anyway, low income is who I did all my, that's who I worked with all of my career. And yeah, no, then factor in, they started taking interest in, you know, white men, yeah, white women, yeah. Where do you think Black women have come in? I mean, here I am, you know, just little me at UD, doing, you know, making sure that, you know, I go to Maranatha and Omega Baptist and those churches and get, you know, all my subjects and everything, just the coolest bunch of women. And I'm able to see that in Black women, they don't have high blood pressure responses, even though all their lifestyle habits are negative. They don't have them up to about age 40, and then it just goes through the ceiling. Whereas with white women, if we're doing bad, we start early with our blood pressures going up and stuff. It's so many racial differences, and we've never adequately characterized those differences in people who just don't matter. You know, I'm being very tongue-in-cheek when I say that, but yeah, so the NCDs are on the rise in the lower SES. Okay, why might that be? They are now the beneficiaries of all of our modern conveniences. I mean, who doesn't have the cell phone and the car and all the modern conveniences and the processed foods and, you know, all of that, right? That has trickled down, and higher SES had early intervention and has been educated into different lifestyle choices. But a lot of those lifestyle choices are lifestyle choices of privilege. Not everybody gets to do that, you know, just from an economic standpoint or time constraints. And we're going to look at why this is still occurring, you know.
Stereotyping that's mixing with those things now.
Oh my God, yeah. Oh, well, you know, it's hard to speak on a topic and not offend anybody. And yet when my slide was up and it was talking about the causes of the illness, America was right in there, and we said it was color, it was race, you know, and that was yeah, I didn't throw it in there because that makes me sick, you know. So anyway, yeah, so we've seen, and you couldn't tell from that previous slide, that not only are NCDs still a monumental problem, but it is getting worse and worse and worse and worse and worse. And the whole socioeconomic burden gap is widening, not narrowing. And so now we do have poor suffering much disproportionately from the NCDs, you know. And so if you go back to the previous slide where I said in 2010, the funding dried up for NCDs because the higher SES started getting better. But it's at the same time that lower SES is getting worse and worse and worse. So is that, I don't know, you tell me. Is it a coincidence? I don't think so. But I'm skeptical of all this stuff. So I could go to the site and get him, and he's just hilarious when you hear his voice.
Me,
But
what I've noticed is over the last 10 years or so, sorry about voice, but it seems like they've monetized food so much now that they're packaging these, what we used to call TV dinners, and pumping them out there as being healthy.
yeah,
And
they learn the buzzwords.
yeah, and it's nobody's cooking their own food,
Yeah.
so they don't really know what goes into that.
Well, and that's that whole trickle down effect of there was a certain social strata that was going to be able to afford the processed foods, convenience foods. And before we knew how bad processed foods were for you, but then it trickles down. But then in order to capture the lion's share, I ate a bag of chips day before yesterday that said it was junk food that's plant-based, and I just snarked that thing up, man. I'm like, whoo. It had like lentil powder and pea powder. It actually had some pretty good stuff, but I was really looking at that and I'm thinking, I would normally hate something that looked like that package, but they are capturing a different audience.
It's looking for that loophole.
Yeah,
It's deceiving
yeah, it's deceiving.
because, see, they make the flavors, they change the names. And because most people are not really aware,
Yes.
they've been changing it like natural flavor. It's not, because a lot of people think natural is good.
Yeah.
But you don't know what's naturally actually. Look at
There's nothing cheese in it. Nothing authentic. There are no authentic ingredients, things you can't pronounce, right?
But if you see 3 ingredients in a product, that's good. If you see more than 3, it's bad.
Yeah, that's true. And if you can't pronounce them.
Don't have them on your shelf.
Yeah, if they're not food. What'd you say?
If they're not an ingredient, you have on hand. to make your own.
That you could make your own food with that. Yeah, no, exactly. No, it is deceitful, but there's more okay. Good point. There's no money going into funding. There's no money going into research to ameliorate NCDs and lower SES, but the money that's going into the phenomenon that you just described, which is marketing bad food to people that are gonna, you could take the exact same thing and put it in 5 different packages in order to get 5 different audiences to eat whatever that was. It's all marketing and packaging.
But not only that, they start with the children.
Yeah.
Because you go to the school, they feed the children, what do you find? You don't find anything that is cooked right there, like a package of beans, just cook it right there. Or you find is packaged food. So who is making the money? If you just come, if you just look there.
No, I love that you are knowledgeable about this. And another one of my research projects was in Xenia, and did a lot of research in Xenia. They're a very interesting population, they're just a cool bunch of kids, but they are off the charts in bad health, to be just perfectly honest. The adults, it's not a good profile. But what we found is we did all this nutrition education. We tried to start with the adults, and Dr. Bear and I said, we're not getting anywhere with these guys. Let's get to the kids. And so we started having nutrition education with children. And then we did all the diet histories and all that stuff. And what we found over time was if there's only one child in a family, they are not overriding what the parents, what they're going to get from the grocery store. But if we have had at least 2 children in the same family, the parents can't wear them down. They wear the parents down, and there would actually be some change occur in dietary practices, so. But yeah, it is aimed at the kids. And so that's exactly where the reverse protocol has to aim, is at the children. Sometimes the adults on non-communicable diseases, well, there's a slide here coming up, and it's the next.
But one more thing I want to say is the free food that is offered to the school, so the children cannot.
Oh, those are bad, that's bad. Food
Because
choice
my
of
child
trust.
was like in second grade. I mean, he saw the other kids who went to the school and eat the breakfast right there. So he wanted to eat it too. And I said, well, you can have just one day. You can have one day.
I worked at a school district and worked with the kids when they came in for breakfast in the morning.
Yeah,
That stuff was dog food. I mean, it was tight. You're eating it. And then lunch was much better, you know, at least in the district I was working in, it was.
oh, I know, I was there during lunch, it was a lot of times, it was just. Yeah, and that's, I mean, they would trust that to be good food, the children might trust that to be.
Well,
good
because the
food.
children don't know.
They don't know.
And
No.
the parents trust that the school is gonna feed them good food, but. There's a lot more.
No, it's huge. The problem is large, right? But the solution starts on a very small level. You know, and I'll get to a few slides.
Back in these schools now, can I contribute to this too?
The what?
Home ec, because they used to have home ec classes.
Oh, they don't have that anymore?
Oh, no.
See, that's
Why?
Oh, I don't know. I mean, God.
It's been going for 20, 30 years. It's along with the shop classes, probably not big, not that long, but it's probably been about 20 years in a lot of this districts.
Wow, yeah, well, then they're not learning about food. Home ec was a very, very good training ground.
For anybody, I mean,
I wonder what they would do with it now, though.
Free food.
Free food, yeah, right, never mind we had some bad kids in my home ec class, and when they were baking the brownies, they were putting their own ingredients in, that's all I remember. I was scared of the brownies.
We are paying for it.
Okay, so this is kind of a, you know, do we care? And this thing has been very difficult to get him to move forward, and so there we go. Do we care? Well, of course we do. You know, we really care. The government cares, the wealthy, everybody cares about the fact that low SES is not just us, everybody cares. Just look at all these initiatives. In 2000, Healthy People 2010 campaign highlighted and set targets for reduction of health disparities. We care. We didn't do anything, but whatever. We said we cared. In 2002, National Academy of Medicine report came out with unequal treatment, confronting racial and ethnic disparities in healthcare. That really got people's attention, but you can't really do a lot with attention. You need money. The American Medical Association voiced commitment to disparities reduction by 2004, if not earlier, and this is then being reported in the AMA publication in 2022, that's reporting on their failure. The Accreditation Council for Graduate Med Ed began requiring health disparities education for residents since at least 2004. But the curricula are not being implemented. And here we go again. WHO is now out with, no, by 2030, no, now we're gonna do it right, okay? Now we're gonna do it right. Reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment. And throw another impossible goal in there that you're gonna promote mental health and well-being, okay? So, but more than 2 decades go by and the gap is widening, the numbers are increasing, it isn't happening, yada, yada. You know, it's just, I just say, here we go again. I mean, even in my lifetime, I have been through all of these cycles in academia and listening to this stuff. And it's almost comical, okay? Why? It's not easy, okay? It's really complicated, and there's one model that helps us kind of look at this. It's the capacity load model. Basically, the more exposure you have to the deleterious ingredients of poor health, okay, it's additive and it's a dose-dependent response. Individuals living in low SES have more exposure to all of the, like, environmental toxins and things like that. Children, before they're born, you can do amnio testing and find immunocompromised fetuses if they're being raised in low, like, environments that have toxicities, that they're close to bad factories and the fumes, or if there's, you know, been chemical industry in the area and then is being, you know, covered and earthed over. But those toxins, that property value just plummets. So now who can afford it? So that's what we do, you know, and you can bring people in and treat them, and then you send them right home to the environment that's causing all the problems. So that's why this is really difficult, because it is an additive model, years and years and years, and it's starting in children. Poor nutrition of the mother, poor nutrition of the fetus, environmental toxins, what else? I mean, and then the children are really at a disadvantage, because like what we were talking, the kids depend on the adults. You know, the adults may be depending upon the school systems and everything else, but it's a really complicated situation. It's systemic.
From economic basis.
And then you have the issue of so many people without health insurance, or without adequate,
Yeah.
or especially without preventative health insurance.
They don't have that. That's, in fact, that's, you guys, every time you bring a point up, it's the very next slide. So makes me very happy. So, but increased exposure and decreased access to health services, you know. The NCDs are really serious because they can cement people into the lower SES. It's a slippery slide. If you're living close to low SES and you develop a non-communicable disease and you go without a paycheck for a little bit, or this, that, and the other thing, you can slide right into low SES, and getting out of the low SES has been shown to be nearly impossible. Okay, we can talk about the American dream and we can all come up with one example, but we're not talking about that. That's not the number we're talking about here. Okay. Yeah, I mean, with the resources of the household quickly can be drained when you're really paid, you know, paycheck to paycheck and no margin for lowering your standard of living. You are already living at the minimal level that you can survive on, you know. Okay, let's take a step away from this and just, I don't know that I need to go through every one of these. I've got a slide for each risk factor, but just let it suffice to say that unhealthy diets, okay. Individuals living in the lowest decile, it would actually consume 70% of their entire household income just to follow healthy diet guidelines. Okay, what about rent? What about, you know, like,
Yeah.
you know, paying the bills and things like that, and all the bad food that's readily available. And then obesity, this is going to be kind of the same thing over and over again. It's just that individuals in low SES, with all of their exposures and dietary exposures and things like that, and the gut microbiome of the mother while carrying the fetus, and the microbiome that the baby's born with, all of this leads into a problem with obesity. We established that early in life. Some of us have a more difficult time overcoming that. Some have a natural predisposition toward obesity and others not, but it's usually determined quite early on, even pre-birth. And even if you're not overweight as a child and you're in a low SES, your likelihood of becoming an obese adult is huge. Okay, tobacco use, kind of the same story. I'm going to flip ahead here just a little bit. Alcohol consumption. The alcohol is kind of an interesting point because People with lower SES have significantly higher rates of alcohol attributed to hospitalization and, disease burden and death. But they do not purchase the most alcohol. The higher SES purchases more alcohol, but the lower SES suffers more of the deleterious effects from alcohol consumption. And one hypothesis for this sort of discrepant fact is that you take all of the risk factors of low SES, and if two things vary identical, tobacco use and alcohol and poor diet, that's three things, they're all varying at the exact same rate, that's called a collinearity, and it's very difficult to tease out the effect of one from the effect of the other two statistically in research, because we can't isolate the effect of just one thing because it's varying identically with the other factors that are having the same outcome. Psychological stress, off the charts with our individuals living in low SES. And stress is quite honestly at the root of almost every negative health consequence that you can name. And the wealthy people are not getting away with anything on this one. Okay, yeah. So anyway, I've got a cartoon in a couple of slides here that looks at that. Okay, exposure to allergens and environmental pollutants. We already talked about that a second, so I'm going to move on from that. Okay, we talked about that a little bit ago. Physical inactivity, that's like, we all know that one, right? You're supposed to exercise. And, okay, at the bottom of all this, all those things that we just talked about, those are lifestyle choices, right? Alcohol, tobacco, physical activity, diet. Most of those are lifestyle choices. And if we would adopt healthier lifestyle habits, then we could ameliorate the NCDs. Okay. All non-pharmacological. This is why I say it's not a primary care issue. The doctor isn't needed in helping people adopt healthier lifestyle choices. The doctor's needed when we didn't do it. Yeah. And this is the cartoon. Just looking at a whole lot of things that you can kind of follow this down. So we're taking a lot of environmental factors, our lifestyle choices, and then we have to superimpose those on genetic predisposition, okay? Because there is, we are people who have different genetic makeups, and that genetic makeup is affected while we're still in the womb. The DNA itself is affected, and eugenics will tell us that it's affected over our lifetime, but we still do have a basic blueprint, okay? So this is just, looking at the causal pathways between our modern lifestyle habits that lead to inflammation and altered cell immunity, and ultimately to tissue damage, oxidative stress, and our vulnerability to the different disease conditions. Special attention over here to stress and HPA, the hypothalamus pituitary adrenal axis. The stress is going to get all of us. Like I say, the social strata, there's more stress in low SES, but our levels of stress as humans walking the earth are inordinately high. Okay, so bring it up to current day here. So all these NDCs, you always heard about the comorbidities. COVID, comorbidity. These are the comorbidities. That's what they are. It's all the NCDs. Those are our NCDs. So basically the take home here is that, like right at home, 94% of all who have succumbed to the COVID-19 had at least one comorbidity connected to the lifestyle NCDs. And I think we've shown that prior to COVID, our management of the NCDs wasn't adequate. And so now to simply return to that post-COVID is also not gonna be, adequate. It's along here just a minute, but this is just straight from the WHO. It's showing in 2010 that the funding stopped. And it's showing that there's just no money. And most rehabilitation type services were halted during COVID. People didn't want to go in. So a lot of the routine screening that anybody who actually was getting that was also cut way down. And so that brings us to this recent thing saying SDG 3.4, how, by 2030, we're really going to improve stuff again. I hope so.
Yeah.
So I just want to, Kathy, I want you to see these pictures, okay? And then I'll ask the questions here. This is how my professional career has been spent. Screening, that's me. Yeah, so this is my role at UD, was in the field and doing very large scale screening of African-American women and their biological daughters was one huge group. That's me saying, oh, gosh. I mean, it got a little hectic on Saturdays in there. This is my research assistant, Jewel. We did diet histories. We sat down and took 3-day diet histories from every child and every mother. And I mean, this is labor intensive research on very large numbers of people over the years. Made a lot of good friends. So I had my colleagues that I did my research with, but then every single class that I taught at UD was involved in going out to the different, like this was at Lincoln School. And we did all sorts of screening, President's Fitness Challenge testing. And we identified so many children that we were able to have early intervention with. So I can do all the EKGs and all that, blood. We did blood draws on everybody, really made a lot of progress. This is just another group of my UD kids, then me and Jayne Brahler. Another one, and Jewel, young woman in the red up there, second from the right. She was my research assistant, so she's in every one of these. These kids were hilarious, but the challenge testing, cognitive physical tasks. We got them to stop using physical education period. When I started going to these schools, they were using the phys ed period. Kids were lying on the floor getting drilled for standardized test material. They were not using phys ed as a phys ed, period. So they were trying to get them to get better scores on the standardized tests. And so I convinced them that through doing cognitive-based physical tasks, that they would improve on their standardized test scores, because you can improve long-term memory in these kids, and they'll have a lifetime of better, learning of everything and retention and things like that. So now this looks like a different setting, because once they moved me into the Doctor of Physical Therapy program about halfway through my time at UD, and I still got some of my colleagues to go out and do field research, but I was then in the dean's office, and so I wasn't really mobile to go out that much in the field. And so it's a different setting, but it's still good. They're doing yoga with kids at St. Albert's. They're the privileged kids, but they were really cool kids. Okay, so I wanted to hit a few of those pictures before Kathy left, because she's going to the movie. Yeah. So my question at this point is, you know. I don't have any idea what's going on in Yellow Springs, and I don't know if you folks do. I think it'd be worth checking into. I don't know if there's any routine screening or anything like that. This has not, honestly, since I've lived here for 24 years, but I've just always been at UD. And so my community was always, like Dayton, Xenia, and things like that.
Jayne,
I'm just curious.
I'll bring one piece up, and we'll be also, as Diane mentioned, there's a poverty panel coming up.
I heard that,
But-
well, I picked up on that.
Within Greene County, Yellow Springs actually has a larger percentage of people in poverty than the countywide average. Countywide average is 6.7%. Yellow Springs is 9.8% live in poverty.
I think honestly, I'm not shocked to learn that. I mean, Xenia was so familiar with, and that is, sometimes you speak in research terms like I'm a white woman of small body habitus. And we have Appalachian whites, living in Xenia. So I think, how does that sound when I talk about people in that tongue, but it's just fact. And so it does kind of surprise me. I would have thought that Xenia would have the overrepresentation, but Xenia I got about maybe 150,000 or something like that to do research in Xenia. And then that funding got difficult because Xenia became suburban.
Mhm.
Try and get funding for white kids living in suburbia. I was trying to get funding for health research, and they looked like Oakwood on paper, trying to convince governmental agencies to give funding to work with these kids in Xenia. That became problematic.
How does that happen?
I don't know what the stats are that cause an area to go from rural to urban, but it did not help, or to suburban,
It's really the ratio of
in town versus out.
square mile population. It's
Yeah.
population per square mile.
Yeah, we're getting out of my area.
Can I ask a question because I'm ignorant of this? How do we have so many poverty in a very wealthy country?
Or
I don't know, there's a couple social workers in the room. I'm not the only one. I think a lot of it is this ongoing disparity. I mean, we talk about acquired wealth is so common, and it's not just that we have money to pass along to our children. It's also, we had the money to provide education, nutrition, health. All of those things are passed along. The kids who have better chances at getting to college because they have money, and the disparity grows over time because there's people with money that begets money, and there's other folks who never can catch up.
And then they just go down the slide because they are at such increased risk for the health anomalies that then keep them from putting things together. On the mother-daughter health study, a couple of the coolest things that happened, I did the snowballing effect for getting research participants. And that means that if you were one of my participants, well, I'm going to pay you $25 for everyone you can bring in. Yeah, and the Tuskegee trials were right here. So when I went out into the field and was trying to talk Black women and to bring themselves and their kids in for my research, and I'm going to be drawing blood on them, I'm telling you, it took a little bit of talking. They were skeptical, and that melted. But the coolest thing is some of these families and friends, they would bring in so many other people, and they're right out in the neighborhoods. They could get the people, and I paid 25. There were several instances where they put together deposits to move into they could move into a nicer apartment. And there's sometimes 3 like single mothers and the children living in one apartment. But they can move into a nicer apartment, and the reason they got the deposit money that they needed to get into a better living situation was because out of nowhere, this, little UD research study comes along. And yeah, somehow would get enough subjects for me that, they could put together like $500 or $600. So it was funded research, but that's where my money went, right into getting as many subjects and stuff. It was very cool, yeah. I don't know, have you ever heard of the Magic Johnson Bridgescape program? It is high school dropouts, and they want to come back into school, okay? And so they have to come, they've got GPAs of like 1, I'm not kidding. Yeah. And they want to come back into school. And so they are special schools, okay?
What kind of special?
Well, they're high schools, they're accredited high schools, but it's Magic Johnson Bridgescape programs. And so it's only these kids, they're alternative learning environments for kids who have dropped out and are not likely to succeed in a regular high school setting.
Like a JV?
Well, it's face to face. It wasn't an online, it was an actual,
They have tutoring
they have more faculty or teachers per the faculty to student ratio is much higher, and I can't remember. I developed a medical math class for nursing curriculum, and I put that in an online classroom, and then I offered it. I had to jump through hoops at UD, but I actually took students at the Magic Johnson Bridgescape program from Cleveland, Cincinnati, and Columbus. And I went to each school, I made it to each school, me and my research assistants, about once a week, maybe sometimes once every other week. We worked with them online in between, but they were able to take this medical math class for a UD credit. And so what we were trying to do is to show that these kids that are never going to be able to get accepted into a college because their GPA is too low. They couldn't even get back into a regular high school. Nobody wanted to be with them. And these kids, some of them just weren't ready. They didn't do well, but the ones that stuck with it, which was way greater than 50% of these kids, got A's and B's. And so then if they did want to go on and go to college, they could show on their application, you don't have to guess whether I can do college level work. I've got an A in a medical math class from the University of Dayton, so it was just that I did actually when I was an associate dean. I could pull that off, but got so far away from my own personal field work when I got moved down to the doctor of physical therapy program. I moved down there because they had like 6 clinical faculty that needed to get research agendas going and get through the 10-year window, and so they brought me here originally because of research expertise. And so that's where they used me for the last 15 years of my career there, but it was all good anyway. So
Do they ever?
Were offered like a trade school so they can go to learn the trade?
that I don't know, because I was only the one at UD trying to work with them for the college credit, but honestly speaking, that's what I would advise students to do right now, if you want to know the truth. And a lot of,
They're striving
yeah, I don't know that I would be in a good selling position for college degrees, right? I hate to say it, you know.
It's too expensive one, then they, you have to be willing to have.
Well, we got a little more flexible about knowing that kids need to start college and not know what they want to do, and then, you know, structure their coursework so they can get a certificate and get a good job while they try to put the rest of their college together. Then let them not go to college for a while. And instead of having that old rule that we say, if you've not if you've been disenrolled for 5 years, none of it counts anymore. It was ridiculous. how long did it take me to find myself? 5 years, how many times over, you can't expect an 18-year-old kid to start and follow through and not make any money in the meantime. And along the way, if they find something better, I'm promoting that they're getting like trades type certificates. There are a lot of most of the ones I was promoting definitely in the medical field, because that's, where I'm a medical physiologist, that's my deal. So that's kind of my world, but, anyway.
Something maybe we did a few.
Example. Anything else?
I have never heard of this 5-year. And you have to start over again with college, is that true?
I'm positive it's true in graduate education, because I haven't taught at an undergraduate level for a long time. And I know in graduate education, is it 5 years or
5, sometimes 10.
Yeah, but but that's ridiculous, probably. And this is the thing I was pushing for when I was in the associate dean role, is when students, whatever they're out doing for those 5 years that they're not in the classroom, you better be giving them credit for it, because they probably learned a whole lot, and that's giving people credit for military service and things like that. And, at UD, we weren't very good about recruiting people who had military history, and yet some of the positions that people hold in the military, if we can get them in, they've got life experiences that they'd be the best students ever, And so that all that stuff is, I know UD is coming through with a lot more of that stuff now. UD has also gotten where it's valued the diversity of the students and everything massively. Well, they had to, but they do. There's a lot of pressure to put together a better diversity profile in your recruitment strategies and your retention and things like that, But I mean, it looks like they're genuinely behind it. I can honestly say they were not behind it in 2000 when I started. Yeah, I was amazing.
Yeah.
What do you say? God lazy. Yeah, right. Any other questions or anything? I don't know if I got off on, you got me off.
I think the other piece, from a social worker point of view, the other piece is that poverty programs are kind of set up to keep people in poverty.
Yes.
Because you lose your qualification for your medical if you suddenly have assets.
Oh my gosh.
Or you lose, if you get a job that pays more, you better hope they have insurance, because you're gonna lose your Medicaid.
Lose your benefits.
And your housing is tied to your income, and your SNAP benefits, your nutrition benefits are tied to your income. So I know of several young parents who are really excited if they can put their money away in a retirement plan, because that won't count against them.
But they can't
Earn enough money
to
to
get.
get ahead.
Yeah, well, I didn't even think about that.
It's a trap.
Yeah.
It was designed, I think. In my opinion, it was designed.
And somebody probably benefits at a much higher level by getting their quota of people.
The government looks good if they have fewer people on the roll,
Yeah, indeed.
on the dole.
The Yellow Springs Foundation set up a program to give $300 a month to families in town who are living below the poverty level. But I wonder if some of them, that it might be a problem. But there was they did it by lottery. But they're trying to develop an endowment fund that would fund be an ongoing program.
in the lottery, they did do consultation so that
Yes.
people could confer with somebody to know what that would do. with their
I would
benefits.
think they would need to, yeah. Interesting.
Yeah.
Well, thank you. Thank you for coming and talking.
Well, thanks for having me. Yeah. Oh, yeah.
Yes.
If you like them, take more.
There's a wonderful Zoe podcast came out today about gut bite. Of course, they do tons on gut bite.
Oh, okay.
There's a wonderful one that was out today.
That's one of my,
Yeah.
I've got a lot of favorite topics.
Yeah.
Probably best use of one favorite.
Right.
Okay, yeah, thanks you guys for coming out. I appreciate it a lot.
No problem. Really,
Thank you.